Very good evening. Namaste. Greetings from Chess Council of India. Welcome to this Thursday webinar. We are all delighted. For the past 5 years, continuously, we are doing the every Thursday webinar of different topic, different moderator, different speaker, pan-India level. I thank you, CCI team, leader, Dr. CCI Chairman, Trustee, Dr. N.H. Krishna sir, Dr. Narayan Pradeepa sir, and the CCI National President, Dr. Ashish Dubey sir, and CCI National Secretary, Dr. Anil Maske, and all the leaders behind the screen 24/7. They are doing a very hard work. Dr. Atri Gangopathyay, CCI Webinar Coordinator, Dr. Vijay Kumar Channamsetty, Ravi Doshi sir, and Dr. Shivani Swami, and Kirat Sibia. A lot of leaders behind the screen. So 24/7, they're working hard for this wonderful human service to the medical community. Thank you all for this wonderful services. Thank you, Krishna ji, for a nice platform to disseminate our knowledge across the India as well as the world. Thank you. Today, we have a different topic of the presentation. The Chess Council India presents the today's topic, webinar topic is the pulmonary edema. What, where, when, and how to tackle. You all know very well. The pulmonary edema is one of the acute pulmonary edema is one of the medical emergency. So there are a lot of etiology behind. So commonly we come across the cardiogenic pulmonary edema. So chronic pulmonary edema, we call it as cardiac asthma previously. So this is one of the medical emergency. So we have to tackle the problem. So meticulous examination and the detailed history, investigation, and stabilization of the patient in emergency and in ICU. There are all a lot of discussions. We are going to have this wonderful panel. We have the star speakers. Under this scientific webinar highlights, we are going to have the two main important discussion points. One is the pathophysiological mechanisms of underlying cause of the pulmonary edema. And second is the strategies of pulmonary edema management, including the pharmacological intervention and the role of non-invasive ventilation and vasopressor management. And third thing is the analyze the challenges and opportunities, collaboration. That is in managing the pulmonary edema in a diverse clinical settings. And finally, we have the importance of multidisciplinary, interprofessional collaboration and timely intervention in pulmonary edema management. So, may I introduce today's stalwart panelists, star speakers. So may I introduce Dr. Vinit Kumar, subject expert, star panelist, is MD/DM cardiologist, senior consultant interventional cardiologist, Medanta, Ranchi. Dr. Vinit is an ex-professor of cardiology in the LPS Institute of Cardiology, GSVM Medical College, Kanpur. I welcome Dr. Vinit Kumar for this wonderful panel discussion. May I invite Dr. C.H. Sasidhar Channamsetty, Senior Consultant Nephrologist, Apollo Hospital, Hyderabad, Mahavir Wellness and St. Teresa Hospitals, Advisor to the Nephrologist, Apollo Dialysis Center from Hyderabad. Welcome, Dr. Sasidhar, sir. May I introduce Dr. K. Dayanand, sir, Civil Surgeon Specialist, Department of Pulmonology, Insurance Medical Services, Government of Telangana at ESI Hospital, Sanath Nagar. Dr. Dayanand sir is a visiting consultant, pulmonologist in Apollo Hospital, Secunderabad, Basavataragam Indo-American Cancer Hospital and Research Institute, Hyderabad. Welcome, Dr. Dayanand sir. May I introduce, last but not the least, Dr. Neel Thakkar, consultant pulmonary and critical care physician, Pulse Clinic and Sterling Hospital, Vadodara, Gujarat. He has many paper presentation, 45 paper presentation in national, international, and many awards, member in various societies. So with that, we'll begin our flow of the event. So there are today's discussion mainly the pulmonary edema. So we call it as pulmonary congestion, water in the lung, and the lot of names. So fluid loaded lung, inside, in between, or interior. So Chest Council of India proudly, we are presenting this topic on pulmonary edema. The flow of the event will be the first talk by Dr. Sasidhar, Channamsetty, nephrologist from Hyderabad, will be talking on pathophysiology of pulmonary edema. Followed by, we have a second talk, management of pulmonary edema by Dr. Neel, Thakkar, pulmonologist and intensivist from Vadodara. So I begin the presentation. May I invite Dr. Sasidhar for the topic of pathophysiology of pulmonary edema. Over to Sasidhar, sir. Thank you.
Thank you, CCI and Dr. Jayaraman, for giving me an opportunity to speak on pathophysiology of pulmonary edema today. The definition of pulmonary edema, it is a life-threatening syndrome caused by excessive fluid transition into the alveoli due to alteration in the Starling process. So normally there is a pulmonary homeostasis, there is an equilibrium between forces that drive fluid into alveolar spaces and counter forces responsible for its clearance, mainly the primary lymphatics. So here in this diagram, we see the pulmonary edema, normal alveoli on the left side with normal lung. In an affected lung, we see the fluid in the alveoli. So pulmonary edema will occur when there is delicate overcome by impaired clearance mechanism, increased hydrostatic pressure resulting in excessive pressure gradients and permeability of the capillary alveolar barrier. So pulmonary edema is basically divided into cardiogenic versus non-cardiogenic. Increased pulmonary venous pressure leading to cardiogenic causes and increased permeability leading to non-cardiogenic pulmonary edema. So basically, very important slide, the Starling equation. It is a fluid balance between the interstitium and the vascular blood in the lung, as in other microbes, circulation is determined by the Starling relationship. Formula negation is equal to K into delta hydrostatic pressure minus the delta oncotic pressure. So the cardiogenic causes of pulmonary edema mainly is divided into systolic dysfunction because of impaired left ventricular contractility resulting in reduced cardiac output. It is the most common predisposing condition leading to cardiogenic pulmonary edema. Next is coronary artery disease, hypertensive valvular disease, idiopathic dialytic cardiomyopathy, toxins, metabolic disorders like hypothyroidism, viral myocarditis, Coxsackie B virus, and echovirus infection. Coming to diastolic dysfunction, mainly the left ventricular hypertrophy of any etiology, hypertrophic and restrictive cardiomyopathies, acutely with myocardial ischemia and acute hypertensive crisis. So this is the basic mechanism by which there is early phases of acute heart failure leading to pulmonary congestion because of vascular pathway, cardiac pathway leading to pulmonary congestion. So a word about renovascular hypertension, how it causes flash pulmonary edema. There's an association between recurrent pulmonary edema and renovascular hypertension, which was first described as by Pickering et al. So it is also referred to as Pickering pulmonary edema, where it is common in bilateral renal artery stenosis of almost 41% compared to 12% with unilateral renal artery stenosis. Coming to the second topic of non-cardiogenic pulmonary edema, the predominant pathophysiology is accumulation of fluid and proteins in the alveolar spaces leading to decreased diffusion capacity and hypoxemia and shortness of breath. The main mechanism is rise in transcapillary filtration, is an increase in capillary permeability. So the pulmonary edema due to ARDS is basically because of the alveolar capillary membrane becomes damaged and leaky. In case of permeability, pulmonary edema allowing increased movement of water and proteins from the intravascular space to the interstitial space. Normally, we see that the concentration of protein in the interstitium exceeds 60% of the plasma value. ARDS can be seen in a number of disorders, mainly sepsis, acute pulmonary infection, non-thoracic trauma, inhaled toxin, DIC, shock lung, cocaine smoking, post-coronary artery bypass grafting, inhalation of high oxygen concentration. Sepsis or ischemia induced release of cytokines such as IL-1, IL-8 are also common causes. Other causes of non-cardiogenic pulmonary edema include high-altitude pulmonary edema, neurogenic pulmonary edema, reperfusion pulmonary edema, re-expansion pulmonary edema, opioid overdose, salicylate toxicity, transfusion-related pulmonary veno-occlusive disease, and viral infections. Thank you. I now hand over the mic to Dr. Neel Thakkar we'll be discussing about the further topics. Thank you.
Thank you, Dr. Sasidhar, for an excellent discussion on the pathophysiology of pulmonary edema. My name is Dr. Neel Thakkar, and we'll be discussing regarding the management aspects of pulmonary edema. Thank you, Chest Council of India, Dr. N.H. Krishna, Dr. Vijay Kumar, Dr. Atri, and the entire CCI webinar team for holding these sessions for the benefit of all the pulmonologists pan-India. When we talk about pulmonary edema, we need to know that this is a team approach. So today we have a panel with a nephrologist, with a cardiologist, with pulmonology, critical care, and radiology, as well as pathology. All these play a synergy. So again, this is a classic case scenario. Suppose previous day a patient is admitted with ischemic heart disease and COPD under medicine department. Suddenly at night, the patient's oxygen requirement is increased. The staff increases the oxygen, multiple fluid boluses for hypotension at night. In the morning, patient is sleepy as well as in distress. And you get a call that in the ICU, we need to intubate this patient. The CO2 levels have gone sky high. So when we face with such case scenarios, we need to know these are all recent news articles which have been published where very important high altitude pulmonary edema, especially Char Dham Yatra, so 58 deaths in 16 days. This was last year in Uttarakhand. Again, as healthcare professionals, for even celebrities such as Maradona, as well as doctors themselves, this was a case of a doctor in Delhi where the patient underwent an angioplasty, had an underlying pulmonary condition. Eventually, the patient died due to pulmonary edema. But the doctor was found negligent as patient did have an underlying medical pulmonary condition. Also, there were other issues in that particular case. But patient had undergone an elective procedure and collapsed later. Second, one more case where the jury found a pulmonologist liable to monitor the patient. This was an elective procedure of a patient where the physician had admitted the patient with community-acquired pneumonia. Pulmonologist was referred, underwent a bronchoalveolar lavage as well as a transbronchial lung biopsy. Post-procedure, patient was shifted back to the wards without monitoring. By evening, the patient had cardiac arrest in the wards. So again, in this particular case, the reason was pulmonary edema, but the patient wasn't monitored immediately post-operative. Similarly, this was a Kannada actress where he went up elective plastic surgery, daycare procedure, had pulmonary edema at home later. By the time brought to the hospital, was brought dead. So again, all these cases very important to monitor and know where to look for pulmonary edema and manage it timely. These are various recent devices which are now available, which can be attached to the stethoscope or even mobile phone, which help us in managing pulmonary edema as well as screening it early in the ICU to prevent complications later. Three main celebrities: Rene Laennec, the man who found the stethoscope; Ian Donald, the man who found the ultrasound, which is the modern day stethoscope; and Rinker and Shaw and John Emerson, who found the ventilator, which is again a most important utility when we deal with pulmonary edema. We identify whether this is non-cardiogenic or cardiogenic. Look for the extremities, is it warm or cold? Looks for the heart size. Look for the JVP, is it high or not? Is the third heart sound present or not? Is there any cardiac murmurs which are heard? Is the ECG showing any signs of cardiac problem? Is the pro-BNP levels high? If it is only cardiogenic, it should improve with non-invasive ventilatory support, oxygen or diuretic therapy. If it is non-cardiogenic, based on the etiology, it can take a longer time. We define the cardiology. If it is a cardiologic pulmonary edema, we define is it without heart failure, without edema, with edema, shock, high output or right heart failure. If it is decompensated heart failure, we again have to characterize is it gradual onset, is it slow onset, are there any other symptoms, breathlessness, cough, abdominal pain, any neurologic symptoms. Look for signs of congestion, raised JVP, is there hepatojugular reflux which is present or not. Look for the classic RALS as well as pedal edema. When we talk about coarse crackles in pulmonary edema, this is how they sound like. You can make out this is inspiration, this is expiration, this is the pitch. Make sure that you hear the pitch of this sound. It is a very low pitch sound and it is a popping or bubbling sound in coarse crackles compared to the fine crackles. And again, the fine crackles can be longer in duration and do not have any specific predilection to any area. Cardiac examination based on the etiology, you might find specific murmurs. We'll have a discussion with our panel cardiologist. And again, we look for severe pulmonary edema. The accessory work of breathing will be high. the oxygen levels will be low. The patient will be having a low SpO2, high pulse rate, will be maybe obtunded. In such cases, also in patients with shock, we look for cold cami extremities as well as tachycardia and tachypnea both. High output failure can occur with anemia, obesity, thyrotoxicosis, liver failure, or underlying Paget disease. Right heart failure can occur in patients with pulmonary embolism with a dilated RARV and severe tricuspid regurgitation. So these four to identify, is it warm, dry, wet, or cold, wet. This will help us in management of the further condition, especially with respect to whether the patient requires fluid, whether the patient requires inotrope, whether the patient requires diuretic. So profiling is important. X-ray, you can have a butterfly pattern or septal distension and hilar congestion. Gradually, perihilar consolidation can also mimic a pulmonary edema. This patient can have also ECG changes with LV strain pattern, which can mimic which can be because of subendocardial ischemia, which can cause flash pulmonary edema. Lung ultrasound is the modern stethoscope. Such vertical lines, which are known as B lines, with sliding of the lung, which can be seen. More the number of B lines, more the severe edema, more the aggressive management needed. If you have spared areas, then again, it could be because of ALI or ARDS. If you have dependent B lines, it could be because of pulmonary fibrosis. This is the blue protocol, which can identify which stage, whether lung sliding is present, stage 1, whether there is A profile, B profile, or C profile. If it is B profile, it is pneumonia. If it is again consolidation, and again in B profile, we look whether sliding with B profile, then likely patient will have pulmonary edema. So we identify this is the A profile again with sliding. We can make out the A lines with the sliding, no B lines. This is A profile without sliding. This is B profile with sliding, and this is B profile without sliding. So these profiles help in day-to-day diagnosis as well as management. This is with treatment if there is deaeration or reaeration. If there is more fluid, we will find that increasing wetness, B lines will increase, gradually effusion as well as atelectasis will develop. With therapy, we want that this should come to this stage. So it helps us in treatment. And if there's an effusion, we try with diuretics. If it is causing significant hypoxia, we go for therapeutic aspiration where needed. IVC assessment also helps us in the ICU. A pro-BNP level can be a very helpful marker to prognosticate as well as to treat pulmonary edema. There are various cutoffs which have been recommended. This was an article published in Heart Circulation by AHA in 2020. So the age, arrhythmia of atrial fibrillation and renal function can affect the NT-proBNP levels, and the ratio also of the NT-proBNP and BNP levels more than 6 was found to be very significant. So the goal of therapy in pulmonary edema is that we improve symptoms, restore normal oxygenation, optimize volume status, and identify and treat the etiology. Also, we look for a definitive cardiac cause. If there is an amenable intervention such as revascularization device or anticoagulation therapy, we need to go for it in consultation with the cardiologist. Initial therapy, ABC, oxygen therapy, vitals assessment, prompt diuretic therapy is important. Early vasodilator therapy with urine output monitoring is important. Supplemental again, we look for any accessory if the work of breathing has increased or not. We also do a proper RS examination where needed. In COPD patient, target saturation is 88 to 92, otherwise more than 95. We look whether this patient needs immediate ventilation or try an NIV support. Short case, middle year female, fever, cough, breathlessness, normal counts, create was around 1.2, baseline bilateral basal opacities were present. Was given multiple antibiotics, steroids as well as diuretics in an outside hospital. Hypotensive, increasing oxygen requirement. This was the lung window, right lung and left lung. Multifocal bilateral patchy consolidation was made on the CT scan. Patient had basal crepitations which were there bilateral basally. With this presentation, initially inflammatory markers were high. This patient had a type 1 respiratory failure. IVC was mildly collapsing, EF was 55%, and had a presentation like this. So Berlin ARDS, we all know, we look at the PF ratios to prognosticate the patient. LVF and ARDS can coexist, and to define ARDS, we need to rule out any cardiogenic cause of pulmonary edema prior. ARDS can be because of opioid, eclampsia, trali, or even acute kidney injury can cause a uremic lung. Permeability pulmonary edema is because the alveolar capillary membrane becomes damaged. So what should we do when we find such a case? In this particular case, we did give a trial of HFNC initially, then NIV. Then these are all the salvage strategies in ARDS. Florali trial in 2015 showed that HFNC can affect 90-day mortality. Again, multiple trials which found that NIV has conflicting data. Lung safe study showed that with NIV failure occurred in mild, moderate as well as severe ARDS cases, and independently it was associated with higher ICU stay, and ICU mortality was higher in NIV than invasively ventilated patients, especially with PF ratio less than 150. This was a subgroup analysis specifically for pulmonary edema where they found younger age group, lower driving and plateau, and peak pressures had better prognosis, and higher airway pressures that were related to higher mortality. When we choose NIV, we need to be sure which patients are the best. Higher CO2, pulmonary edema, COPD exacerbations likely to respond, but trials should be very short in such cases. Young age, lower Apache score, intact dentition, again, good candidates. If upper airway abnormality, obstructive disease, neurologic problem, not good candidates. Again, going further in that case, initially HFNC, then NIV, antibiotics optimized, antifungal added with reports later. Patient had midnight hypotension, developed a right side pneumothorax. Again, central line was inserted, and even post the pneumothorax, a right-sided ICD was put in to help the pneumothorax. Lung expanded with respiratory acidosis and hypoxia. Patient went in for invasive ventilation later. Even prone ventilation was needed. So again, we need to identify which patients are good candidates for NIV and which are not. And this patient was continued with lung protective ventilation. Lines were changed. ET showed Klebsiella. BioFire showed RSV. Antibiotics were optimized. Later, with rehabilitation over the 2 to 3 weeks, we were able to discharge this patient. Before discharge, the CTPA revealed that segmental embolism were also present in this case. So again, patient gradually discharged after a turbulent course. So HFNC does have an important role, but should be given within the early first 30 minutes. And compared to other NIV modality, it is helpful in specifically it can reduce the intubation rate and greater clinical benefit in heart failure patients, but with normal CO2. Diuretics are a cornerstone of therapy. They should be ideally used early in patients with pulmonary edema. And around 80, this was a Cochrane study which showed 80 deaths were avoided for every 1,000 patients treated when treated with diuretics. The ability to do exercise were improved, and average age of participants was around 59 years in this particular Cochrane study. So again, loop diuretics helped in acute decompensation. Aldosterone antagonism with spironolactone or eplerenone will help to minimize the potassium loss. Furosemide is the choice of agent. Torsemide or bumetide may also be used. This study published in Jan 25, which showed the difference between torsemide and furosemide. Despite superior bioavailability of torsemide, the deposition of furosemide in the renal tubules was result in a longer action. So dosing again 20 to 40 mg furosemide equivalent helps in such cases, and a lesser response if the patient has decreased blood flow, hypotension, or in such cases, again, treatment with diuretics in patients of volume overload helps, and IV should be preferred over oral, and earlier the better. This is the door to furosemide time was 90 minutes was found to best with best outcomes and lower hospital mortality as per the study published in 2017. Furosemide, it can require in patients who are already on diuretics a higher dose, 2.5 times as needed. Infusion can also be used up to starting 5 mg per hour and up to 20 mg per hour in patients with a lesser EGFR. We should monitor signs of congestion, oxygen, as well as weight in patients where we are using regular diuretics, as well as the hemodynamic effects. If the patient has hypotension, we bring the pressures up using either a very low dose of inotrope or vasopressor where needed. Monitor the renal function as well as the BON create ratio in such cases. If there is an AKI, look for nephrotoxic drugs, other obstructive uropathy or other causes. Also, if the patient is over diuresed, we look whether there is a pre-renal cause for this particular case. There are two specific etiologies. We'll discuss this in the panel discussion: the sympathetic crashing acute pulmonary edema and the fluid overload subacute pulmonary edema. Sodium and fluid restriction is important. Sodium less than 2 gram, fluid 1.5 to 2 gram per day. Venous thromboembolism prophylaxis using heparin or fondaparinux in cardiac cases as well as in sepsis cases. Tolvaptan is helpful, particularly in cases where the sodium is very less, but there has to be a caution of hepatotoxicity in such cases. And again, ionotropes like dobutamine or milrinone can be used where needed. These are two guidelines which are helpful: the AHA 2022 guidelines and the ESC guidelines 2023 for further reading on this topic. Thank you so much for your patient listening. We need to identify the profile of decompensation with pulmonary edema, whether it is cardiogenic or non-cardiogenic. Decide on a good ventilation strategy, low pressures. There is a role of NIV or HFNC in pulmonary edema, especially with no hypercapnia. Role of dynamic assessment, USG profiles we have discussed. Diuretics is the cornerstone of management with good multidisciplinary management. Good pressures are important to prevent acute kidney injury. This is always a team approach. So again, going forward to a very insightful and good panel discussion on this particular topic. Thank you so much for your patient listening. Thank you.
Welcome back. We had a wonderful talk by Dr. Sasidhar on pathophysiology of pulmonary edema. There are a lot of theories behind the pulmonary edema: cardiogenic and high altitude, neurogenic, and the other etiologies. So broadly classified into cardiogenic and non-cardiogenic pulmonary edema. So different pathogenesis. So Starling's pressure, Starling's equations are very important. So there is a pressure differentiation between the hydrostatic and non-cardiac pressure. So the abnormal accumulation of the fluid from the extravascular in the lung parenchyma, which leads to pulmonary edema of different etiology. So wonderful, Dr. Sasidhar sir, for the crisp and clarity presentation on the pathophysiology. And so we had a wonderful talk by Dr. Neel Thakkar about the management of pulmonary edema. So what are the diagnostic tool, ultrasound, and various technologies to confirm the diagnosis quickly in the emergency room, and the management, drug management. So drug of choice is diuretics, loop diuretics, and the ventilatory management. So when to give the HFNC, NFE, NAV and all. So wonderful, awesome take-home points, Neel. So we had a wonderful topic. I am Dr. S Jayaraman, moderator of this panel discussion. I am from Chennai. So welcome back all the panelists, our subject expert cardiologist of this panel discussion, Dr. Vinit Kumar. Welcome, sir. And Dr. Sasidhar sir, subject expert again, nephrologist from Hyderabad. So Neel Thakkar and Dayanand will begin our panel discussion. So we had a wonderful talk overview about the pulmonary edema, pathophysiology, diagnosis, management. Now we'll have the questions. I request all the delegates, those who are joined in this meeting, kindly post your questions. We'll address appropriately. So we'll begin our panel discussion. May I ask a question to Dr. Dayanand sir. Dayanand sir, pulmonary edema, there are two acute pulmonary edema. So this is one of the medical emergencies. So patient present at late night or early morning or any time, present to the emergency department with a history of cough, breathlessness, tachypnea, crackles, hypoxia, and all. So in the emergency room, you are the duty on-call pulmonologist. So what are the differential diagnoses of pulmonary edema based on the clinic? Over to Dr. Dayanand, sir.
Thank you. First of all, let me thank my brothers, NH Krishna, Atri, Vijay, and my sisters in the CCI team for inviting me today for this interesting session on pulmonary edema. In fact, as I was going through preparation, I received a call from my hospital saying that today is my call day, though I had cancelled all my appointments. And ironically, the patient was in pulmonary edema. And there was a confusion between, was it a cardiac MI followed by this thing or a LRTI with pulmonary edema. So basically, all the causes, whatever the disease process cause pulmonary edema are the differential diagnosis for the pulmonary edema itself. So a good clinical history is very, very important here. not only the present, but also the past. Whatever treatment, kindly, the thing is, we have to go through the every record what is available with the patient to come to a diagnosis. It is just not that you are taking your diagnosis based on what the finding is. Like, basically, the patient will present with breathlessness, cough with expectoration. Sometimes it is frothy, pink. That is very characteristic in the textbooks, and in our school MBBS days, we have been taught that pink frothy sputum, it is pulmonary edema of cardiac origin. So patient, we have to see whether the patient is a known case of renal failure or receiving dialysis and all. These kind of patients also can present with pulmonary edema at times, flash. And then cardiac, chronic conditions like mitral stenosis can sometimes present with pulmonary edema. So these are the things which we have to keep in mind. And thorough clinical examination. Don't forget to check the JVP. As Neel rightly pointed out, check for the extremities, whether they are warm or cold. Check the BP. Don't hesitate to look for the pallor, icterus, or any leading clinical aspect which can lead to a diagnosis or a working diagnosis towards the etiology of the pulmonary edema.
Thank you, Dayanand sir, for a wonderful, crisp and clarity answer for this differential diagnosis based on the clinical settings. So clinical history is a very, very important. Detailed examinations, JVP and pitting pedal edemas, all the important. So thank you very much, sir. So the question to Dr. Vinit Kumar. So once a patient comes to emergency, clinically we made the diagnosis of pulmonary edema. We have a slight dilemma whether we're dealing with a viral infection causing the pleural effusion or a cardiac failure causing the pleural effusions. So any biomarker, what are the biomarkers to diagnose pulmonary edema? Vinit Kumar sir. Dr. Vinit Kumar sir? Okay, I'll come to the later. So may I ask a question to Dr. Sasidhar sir? So you presented very nicely about the pathophysiology of the pulmonary edema. So mechanisms of pulmonary edema are all the same, like cardiogenic, non-cardiogenic, high altitude, nephrogenic, then neurogenic, or any organ-specific pathogenesis. Can you throw some light on the mechanisms of the pulmonary edema, sir? Sasidhar, sir. Just increase your mic volume, sir. Sasidhar, sir. Just increase your mic volume and you come to the very closer to the mic. Vinit, sir, I will come to the later. Yeah, now we can. Yeah, proceed. Sasidhar, Sasidhar. No, still voice is muffled only. Muffled only. You close to the mic, sir. Others able to hear? I am hearing very muffled voice only. Yeah,
we are hearing less voice.
Yeah, less voice only. Yeah. Just increase the mic volume. You just adjust the mic volume, sir. I'll come to the Vinit Kumar now. Vinit, sir. So in the case of pulmonary edema, yes, sir. Vinit Kumar, sir, pulmonary edema in the emergency setting, we are seeing.
Yes, sir. I can hear you.
Yeah. Pulmonary edema, the pleural effusion, we have a slight dilemma. Whether we're dealing with a viral pneumonia or atypical pneumonia causing bilateral opacities with the pleural effusion due to pneumonia origin, or is it related with the cardiogenic or nephrogenic? What are the biomarkers to diagnose pulmonary edema, sir? Biomarkers.
Generally, sir, in our day-to-day practice, we use NT-proBNP as a marker for pulmonary edema, but it has certain limitation, like in severe sepsis, in case of renal failure or some severe infection, it can have false positive elevation. But we look at the amount. If quantitative NT-proBNP is very high, we are hearing some ECG changes in echocardiography. although it's not available everywhere, but in good setup, we had a focus assessment in our emergency to look for curly B line and size of IVC, to look for the cardiac contractility, ECG, some ST segment changes, some tachycardia, some bradycardia. All these change when associated, and on top of that, a good clinical history. Suppose uh, a patient came in our emergency with a I have a severe chest pain, and after that, I am not able to lie down from last 2 3 days. Most common scenario in day-to-day life we see in our emergency. Some MI patient, myocardial infarction patient, he has a severe pain, and he takes some, antacid, and pain goes. But as day passes, his LV function deteriorates, and after 2 3 days, when significant drop in LV ejection fraction, patient then came to our emergency complaining of severe dyspnea. And upon taking history, he say, I am a non-diabetic, hypertensive, tobacco chewer, and I have a chest pain. 2 3 days back, I have taken some injection of pantoprazole and some mucin gel syrup, and it goes away. And from last 2 days, I am not able to lie down. I'm not able to take breath. I'm not able to sleep. As I go to sleep, my breathlessness increase, and when I sit in my chair, I got some relief. So orthopnea, when you hear some added heart sound like S3, S4, we call it a gallop rhythm. In ECG, significant ST elevation or ST depression in multiple leads. That shows the amount of myocardial ischemia. So depending on a patient's symptom, clinical history with ECG changes, to see some of the ischemic cardiomyopathy patient, I have seen them taking all sort of steroids and bronchodilator from last 5 year, 10 year. And when I see their heart is hugely enlarged, myocardium is dead. So we don't have much option in that case. We can give them option of left ventricular assist device or transplant, that not readily available at every center. But
Yes.
when you combine the clinical history,
Proceed, sir.
clinical history with ECG, with echo, with B line in ultrasound, with symptom and your stethoscope, your ECG is good thing, and auscultation, cardiac murmur, severe acute dyspnea, sometimes acute severe mitral regurgitation, complication of MI, sometimes ventricular septal rupture, complication of myocardial infarction, and patient end up in pulmonary edema, sudden onset dyspnea with chest pain. So with day-to-day marker of TROP-T, TROP-I, NT-proBNP, and ECG, X-ray, and echo, we can differentiate whether it is purely pulmonary, purely cardiac, or sometimes we can have mixed feature, like in case of severe mitral stenosis, valve is severely obstructed, and in that case there is a flooding of lung fluid, and on the top of this element of bacterial pneumonia, and that can aggravate the course.
Thank you, Vinit sir, for the wonderful update on the biomarkers, mainly the brain nature interpret pro-BNP level. We have to see immediately, and other cardiac enzyme, troponin level. Apart from the clinical history and examinations, bedside echo, all important to diagnose correctly whether is it cardiogenic pulmonary edema causing the pulmonary fluid overload, or we have to assess the other causes. Thank you. Over to Dr. Sasidhar. Sasidhar sir, mechanism of pulmonary edema. The mechanism of cardiogenic, nephrogenic, and high altitude and neurogenic, all are same, or any organ specific pathogenesis, sir?
Unmute, sir.
Yeah, voice is muffled. Still, I don't know. Initially, you had a very good thing. Now, his voice is muffled only. Can you increase your laptop volume?
He may try using headphones, or if possible, if it is feasible.
Right, sir. You please try a headphone or other modalities to increase your volume of sound, sir. Okay. Please just try. I'll come again.
Or the technical team can also help, I think.
Yeah, help. Now, I'll pose the question to Dr. Neel Thakkar. So, what is the role of ultrasound? Yeah. Sasidhar sir, you can join the mobile also. Okay, till the time I'll ask the question to Dr. Neel Thakkar. Yeah, technical team, please guide Dr. Sasidhar sir. And we will move on to the question to Dr. Neel Thakkar. Role of ultrasound as a tool for dynamic assessment of pulmonary edema. Over to Neel.
Thank you, sir. And again, thank you, sir, for your excellent moderation. I'll just like to share a slide here so that we can see. Just a minute. Is the slide visible?
Yes, sir. Make it a full slide. So,
yeah. Is
yes,
it visible?
Yeah.
So now whenever we use the blue protocol here, so we have to define number one, is the lung sliding present or not? And which type of profile is seen? Is it predominantly B lines that are seen? Is it predominantly A lines that are seen? Or is it that there is, and also the lung sliding pattern? So based on these two modalities, we can differentiate that is this what pattern specifically and identify the etiology. As an example, this what we are seeing, this is lung sliding and these are B lines. So we are able to identify that multiple vertical lines here are seen, which are classic of pulmonary edema. So when we define the profile, so A profile here will not have any B lines, it just has horizontal lines as well as you can see lung sliding. So this is one profile. We have A profile here without any sliding. So this again you find there is no lung sliding. So if a patient has pneumothorax, this is the kind of profile that you will find that there are A lines, but there is no lung sliding which is seen. Now, if there are B lines with significant lung sliding, so this profile with many vertical B lines with lung sliding, this is the profile we see with pulmonary edema. Now, if you find there are a lot of B lines, but there is no lung sliding, so then that is the profile which is seen with a pneumonia or a consolidation. Even with ALI or ARDS, we will find many B lines, but there will be sparing of areas. With pulmonary fibrosis, you will find more dependent, posterior or dependent areas where these B lines will be present. Again, C profile is seen with lung consolidation, where you will find thick, irregular pleural line which can be seen, as well as an air bronchogram also you may be able to identify. So using an ultrasound, we can identify the interstitial abnormality as well as which kind of pathology is there. Also important with therapy. Suppose this is a patient with pulmonary edema. Gradually, we find the number of B lines are going up with increasing wetness. And over a period of time, patient can develop a pleural effusion as well as basal atelectasis. So if a patient is going worsening overload, this is how you will find the sonography picture. If you are treating the patient, you are giving optimal diuretics, you will find that there is re-aeration. So over the period of time, this reverse picture will tell you that, okay, the lung compliance is improving and the aeration is improving. This also helps with ARDS, where if you are using PEEP, then we will know that what is the optimum aeration if the lungs are becoming more stiff or the compliance is reducing. That also can be determined using a USG thorax. With pleural effusions, again, to quantify the pleural effusion, as well as if we are putting in an ICD, we are putting in a drain to guide the best site, or even if we are doing a USG guided aspiration, where even for transudative effusions, despite giving diuretics, there is significant hypoxia. So here again, there will be a very significant role of ultrasound thorax. So these are just some clinical applications which ultrasound now has in our day-to-day practice. The ultrasound probe we can also use for the IVC collapsibility. So whenever in an ICU, if a patient is having significant hypotension, or if the patient is having pulmonary edema with hypotension, we have to decide that whether we need to give fluid to this patient, whether this patient requires only inotropes. If we give any albumin to this patient, is this patient going to benefit or not? So such treatment decisions as well as dynamic assessment can be done using an ultrasound thorax, which is now especially in the ICUs, it is a very useful modality. It also reduces the cost of unnecessary medicine as well as prolonged stay if we use it optimally and timely. For some of these slides, Dr. Abhishek Prajapati is a trainer in Gujarat for critical care ultrasound. He provides training for critical care ultrasound programs nationally also. I would like to thank for some of these slides he has shared to help with this presentation. Thank you.
Thank you, Neel, for this wonderful update on the role of ultrasound. Yes, ultrasound chest. Ultrasound is a real-time mode. The various profiles we can diagnose, assess. For the treatment purposes, ultrasound plays a major role as a bedside, easily available tool. So it's a very, very important tool for diagnosing pulmonary edema of various etiologies. Thank you, Neel. So we'll go for the Sasidhar, sir. Are you ready? Okay.
Yes, sir. Yes, sir.
Yeah. Please. So mechanisms of pulmonary edema are all same or any organ-specific pathophysiological mechanisms behind the pulmonary edema, sir?
Yes, sir. Basically, as we just discussed, it is because of the cardiogenic and non-cardiogenic pulmonary edema. And in non-cardiogenic, it is predominantly, other than some elevated pulmonary capillary pressure, there's sometimes fluid accumulation in the alveoli. It depends on the Stirling forces, what we discussed, that formula of hydrostatic pressure, oncotic pressure. The pulmonary lymphatics play a key important role. And coming to the cardiogenic pulmonary edema, it is predominantly because of the high pulmonary capillary pressures leading to cardiogenic pulmonary edema. So basically, there's a mild difference, but I want to further discuss, are we regularly using the swan gas catheters to assess the pulmonary capillary pressure? I would like to ask in the forum.
Yes.
Pulmonary capillary wedge pressure measurement. It is not routinely done, I believe.
Yes, sir.
Yeah.
See, the pulmonary artery catheterization is a gold standard to assess the pulmonary artery wedge pressure and all, but it's available in all the places. Only the interventional cardiology centers only available. So there are various mechanisms: increase in hydrostatic pressure, decrease in oncotic pressure, and increase in capillary permeability, lymphatic insufficiency. There are so many mechanisms behind the organ-specific pulmonary edema pathogenesis. Thank you, sir. So we'll move on to the question to Dr. Dayanand, sir. So what are the radiological features of pulmonary edema? Just now Neel said about the ultrasonographic features. And I'm going to ask you about the radiography, chest radiography, and the CT scan chest-wise. So how to differentiate the pulmonary edema? What are the features of classical pictures of pulmonary edema, sir?
Right, sir. I would like to share my screen.
Yes, please, sir.
I hope it is visible.
Yes, visible, sir. Make it to full screen, sir.
Yeah. So basically, our training has been that pulmonary edema, the radiology is bat wing appearance. But before the bat wing appearance, there are certain processes occur. That is, the earliest this thing will be the red arrow, which is visible here. That is the vascular pedicle. That normally it is just above the aortic arch. It becomes thickened. And the second thing is, normally the vascularity, it is more in the lower zones normally, and the upper zones, the veins are thin, but the reverse occurs. That is known as cephalization of the vasculature. This is one of the earliest findings of the pulmonary edema. Then apart from that, you may find cardiomegaly and all. Then, as we have discussed, there is perihilar You see that the patient is already on pacemaker and all. Then you have a perivascular cuffing of the is another hallmark, which I have tried to enlarge the image. This is again an indication of peribronchial cuffing, is indicative of again pulmonary edema that is progressing further. Then we have the curly A and B lines. All these images I have taken from an article from European Journal of Radiology, Open Access article, which is an excellent review on pictorial review on pulmonary edema. So curly A and curly B lines. Curly B lines are subpleural interstitial thickening, whereas curly A are the lymphatics. Actually, the curly A lines will be longer than the curly B lines. This is what we have to be very much aware of. Then, as you asked, in the CT film, CT film, you will see smooth interstitial thickening. You may find ground glass appearance and pleural effusions also. Then this is a case of decompensated heart failure. You will find all the ground glassing, pleural effusion, cardiomegaly. Then this is a case of CHF. Then wherein you are seeing the classical bilateral pleural effusion and ground glassing. Now this is almost progressing into what is typically described as bat wing, interlobar septal thickening and vascular bundles also, and interlobar thickening is also there. Then this is a rare case where only you are seeing unilateral pulmonary edema, wherein patient has been, it says that it is secondary to the decubitus positioning for a long surgery. Then this is our nothing but ARDS picture, typical. Then this is a common thing which we find out after a thoracentesis, that is re-expansion pulmonary edema after thoracentesis and all, wherein you will find that the pleural effusion has decreased, but the lung is not clear. It is more or less showing increased this thing, alveolar filling and all. Edema is there. Again, the same thing. Now, this is in a case of lung transplant, wherein post-COPD status with asymmetric interstitial opacities in the left, that is reperfusion edema. This is. So these are a few of the slides which I thought I will share. So anyway, so typical is we have to know the this thing, the radiological feature, that is bat wing will appear only in the last stages when the alveolar also are filled with peripheral sparing of the this thing, sparing, so that it appears as though of a bat, wing of the bat. So these are the few radiological signs I found to be shared.
Thank you very much, Dayanand sir, for the wonderful crisp and clarity update on the radiological presentation of pulmonary edema. So the radiography, chest radiography shows there is a KDB lines, bat wing appearance, cardiomegaly, pleural effusion, along with the history examinations, so we can clean the diagnosis. Thank you, sir. May I ask the questions to Dr. Vinit Kumar, subject expert cardiologist. So what are the pharmacotherapy used in pulmonary edema, sir? Drug treatment for pulmonary edema. Vinit, sir?
First of all, sir, I would like to say that we have to understand what is the mechanism of the pulmonary edema in that patient, such as some of the patient of severe mitral stenosis can end up in pulmonary edema. In that case, we have to, before using diuretic in case of severe mitral stenosis, in young patient end up in pulmonary edema, we have to aggressively control his heart rate so that suppose some patient of severe mitral stenosis, his heart rate is like 120, 130. He is in atrial fibrillation with fast ventricular rate. So we have to aggressively control his heart rate so that there is a more time for diastole. And so from LA to LV, blood will go in, most of the blood go from LA to LV in diastole. So by aggressively controlling his heart rate, we can prolong the duration of diastole. So be it beta blocker, be it calcium channel blocker, we aggressively control his heart rate. And then another one thing is diuretic. But before using diuretic, like loop that Dr. Neel has nicely described about the use of loop diuretic, be it furosemide or torsemide. But my personal preference is like furosemide. because it's also, beside this diuretic action, it has also been effect on venodilatation. So when you use this diuretic, the action time duration which take for diuretic like 30 minutes, 1 hour, but for venodilatation it's like 10 minutes, 20 minutes, what we use in Lasix. So our aim is to decrease the preload, to decrease the afterload, and to in case of arrhythmia, to control his or heart rate aggressively. So to decrease the preload, we have some of the wonderful drug like high dose of nitroglycerin. High dose of nitroglycerin. In day-to-day practice, you give sorbitol tablet to MI patient for relief of chest pain. But when you give 5 milligram, it like 60 or 100 microgram of IV nitroglycerin. So before starting this nitroglycerin infusion, you can give them this sublingual nitrate 5 milligram at the interval of 5 minutes, and that will reduce his preload and that will reduce his afterload. Again, next point is this diuretic. If your afterload is very high, like in patient of hypertensive crisis, pressure is like 180, 190, 200, and you are only giving diuretic, but afterload is very high, so the delivery of diuretic to kidney tubule will not be adequate. So for acting before giving diuretic, you have to aggressively control his blood pressure to reduce afterload. And by reducing blood pressure from 180, 190 to 160, 150, and then you can give this diuretic, and then there will be adequate delivery of your diuretic to kidney tubule, and then diuretic action will take place. Because in heart failure, you know, there is an increase in afterload. So before giving diuretic, if patient BP is supporting, you have to aggressively bring it down, and then you can give this loop diuretic. So two therapy, one is diuresis and another one is to decrease preload and decrease afterload. And for decreasing this preload and afterload, we generally use nitroglycerin injection continuous infusion. Before starting this infusion, you can give them sublingual nitrate if BP is supportive. If BP is like, but some patient in shock, in that case, you cannot give nitrate. If some patient has history of taking some drug like sildenafil or Viagra, we can, before using that nitrate, you should ask for history of using Viagra or sildenafil. Like some patient with pulmonary hypertension use this sildenafil tablet. In that case, if you give nitrate for reducing preload and afterload, in that case, dangerous hypotension can happen. But if he's not taking sildenafil or Viagra, BP is supportive, before giving diuretic, you should give adequate dose of nitroglycerin to reduce afterload and preload, and along with that, give high dose of IV diuretics. And sometimes you can give continuous infusion of diuretic depending on the volume status, IVC status, V lines, and all that. So from my point of view, this nitroglycerin diuretic injection and to control blood pressure, some arrhythmia, patient is in atrial fibrillation with fast ventricular case. In case of severe mitral stenosis, severe mitral regurgitation, you have to aggressively control their heart rate also, so that LV has more time to feel. When you bring down heart rate from 150, 160 to like 90 or 100, diastolic period will be more. So there will be more flow from left atrium to left ventricle. And when blood flow from left atrium to left ventricle, LA will be unloaded, and then it will accept blood from pulmonary vein to LA. But if heart rate is very high, LV in diastolic tachycardia, there is a diastolic period is very less. And we know most of the blood flow from left atrium, 80% of the blood from left atrium to left ventricle in diastole. So when there is a tachycardia, there is a reduction of diastolic time from, so blood from left atrium to left ventricle will go down very in less amount. And when you control his heart rate aggressively, there will be prolongation of diastolic time after controlling tachycardia with beta blocker or calcium channel blocker. So there will be more filling of LV from LA, and there is a reduction of LA pressure. And when blood from LA to go to LV, then LA will accept blood from pulmonary vein, and there will be decongestion. So 3-4 drugs like nitroglycerin, furosemide, to and rate control, particularly in case of young patient with rheumatic heart disease, cerebral mitral stenosis. If he is in hypertension, you have to aggressively control his blood pressure.
Thank you.
I hope I am clear.
Yeah, very clear, Vinit Kumar. Thank you very much for the update. Pharmacotherapy management of the cardiogenic pulmonary edema based on the hemodynamics, mainly the heart rate and the blood pressure, the hypertension, any arrhythmias, and we would assess the preload and afterload. The major three drugs, mainly the diuresis, furosemide, and the nitroglycerin, we will check the BP monitoring, all important. Thank you for the wonderful update on the acute pulmonary edema to cardiogenic origin. Thank you. There is an announcement from our CCI chairman, Dr. Krishna sir, put up the message in the WhatsApp group. There are 1,259 logins so far. So thank you all the good hard work behind the team and our panelists. So congratulations team CCI. Thank you. So with that, we'll proceed into the other question. May I ask the same kind of question to Dr. Sasidhar sir? Management of nephrogenic edema. So, Dr. Vinit told very clearly about that, diuresis, NTG, and everything and all based on the pre and after load. So, coming to the nephrogenic pulmonary edema, so what are the assessment and how to proceed with the management in the emergency settings?
So, in the emergency situation, like currently, we are mainly seeing the overall clinical picture, raised EVP, the pedal edema, based on the previous history of any kidney disease, whether they are on dialysis or is a CKD stage 2 or 3, when they are on a lot of diuretics, or whether they are on less amount of diuretics, pedal edema. All this clinical examination will tell us whether the patient is having predominantly of nephrogenic pulmonary edema. Again, nephrogenic pulmonary edema, it can be because of renovascular hypertension, sometimes because of fluid overload status. That especially during the summers, we find a lot of cases with pulmonary edema. Now we have various modalities of how we can treat with pulmonary edema. Previously, we used to put them Lasix infusion. Now currently, there are 2-3 trials which say that early initiation of dialysis is better. Now we have different modalities. If you have a cardiogenic pulmonary edema, you don't want to dialyze the patient, but you have something called SCUF, which can be done on a CRRT machine. There are some newer machines called Apex machine, which will just remove the fluid, but without doing any dialysis. So these are various modalities which have come into newer existence. Clinic pulmonary edema, as soon as we get the history and the labs, because patient with severe acidosis and other things, the best way to correct any pulmonary nephrogenic pulmonary edema will be because of with hemodialysis rather than peritoneal dialysis or any other modality.
Thank you, Sasidhar sir. So after adequate assessment of the patients, so finally, we have to do the dialysis plus the plus or minus peritoneal or hemodialysis. Thank you, sir. So
yes, sir.
Thank you, sir. May I ask a question to Dr. Neel Thakkar? So, what are the best evidence-based ventilation strategy in case of acute pulmonary edema?
Thank you, sir. So, again, we have discussed to some extent NIV in the presentation, but it will help non-invasive ventilation earlier with the preload reduction, preventing the alveolar collapse, especially during end expiration, and decreasing the left ventricular afterload. Numerous studies as well as meta-analysis have showed that this timely use of NIV will reduce the need of intubation, improve the heart rate, dyspnea, as well as hypercapnia, as well as acidosis. One specific aspect which I wanted to discuss, besides what we have discussed in the presentation, was neurogenic pulmonary edema. So in neurogenic pulmonary edema, there is increased interstitial and alveolar fluid secondary to a central CNS injury. So either a seizure or an intracranial hemorrhage or a traumatic brain injury, TBI. Three most common etiology for neurogenic edema. Now, in these cases, we target a relatively higher oxygen because we do not want a secondary hypoxic insult. Besides that, when we target high PEEPs, a high pulmonary positive and expiratory pressure, it tends to reduce the cerebral venous return as well as worsen intracranial hypertension if it is there. So when we use high PEEP in such cases, we should cautiously be using it. And if at all we need to give high PEEP, ideally ICP monitoring where available, it will help us and guide us so that the PEEP is always maintained at a level lower than the ICP. Hypercapnia, again, we try to maintain a normocapnic level in patients with neurogenic pulmonary edema because a high CO2 will cause cerebral vasodilation and increased cerebral blood flow and therefore increasing the intracranial pressure. So again, normocapnia, a relatively lesser PEEP, and again, in cases where we are using NIV with neurogenic edema with an altered mental status, NIV use may be a bit difficult in such cases as the patient may not coordinate with the ventilation. And again, ECMO in modalities where with neurogenic pulmonary edema patient goes into a severe ARDS. In such cases, again, using ECMO may be challenging because ECMO, we use systemic anticoagulation continuously. And with a neurogenic etiology, there is always a relatively high risk of intracranial hemorrhage. So these are some specific points specific to neurogenic pulmonary edema, which we need to take care. Besides this, I have discussed ARDS in my slides that we look wherever there is Berlin criteria within the last 1 week, if there's any insult, PF ratio is very less. We in the ventilation, we target a lung protective ventilation, plateau pressure less than 30, prone ventilation when the PF ratio is persistently less than 150. We prevent any ventilator associated lung injury. These are all in non-cardiogenic pulmonary edema. And otherwise, routinely in the emergency where the patient is not neurologically well, is not has any facial injury. In such cases, even there may be cases with pulmonary edema that require straight off intubation, even though the patient has only pulmonary edema but very hypoxic, unable to, is having neurologic cognition problems. In such cases also, immediate invasive ventilation may be helpful. So and HFNC has limited role with only normal oxygen, where the normal carbon dioxide, not in high CO2 levels, where transiently in the emergency, we can give a short trial of an HFNC, but it has to be a short trial. So these are just some key pointers when we decide, and these are all evidence-based for specifically ventilation strategies with pulmonary edema. Sir, you're not audible.
Now, can you hear my voice, Neel?
It is there, but slow. Yes, sir.
Yeah, okay. Yeah. Thank you, Neel, for this wonderful update on the ventilatory strategies of the pulmonary edema management based on the etiology. Whether is it a neurogenic and brain injuries, and also we have to go for straight away the non-invasive or invasive ventilation, we have to choose appropriately. And in general, we have to start the high flow oxygen and other modalities of the treatment part. Can you hear my voice audible, Vinit and Dayanand, sir?
Yes,
okay.
sir.
Yeah.
Yes, sir.
Thank you, Neel, for this wonderful update on the ventilatory strategy for the pulmonary edema management. So we'll move on to the Dr. Dayanand, sir. Can you throw some light on the high altitude pulmonary edema? This is different kind of pulmonary edema, comes from the non-cardiogenic. So what are the points favor of high altitude pulmonary edema? Any drug prophylactically we have to give? So what is your take on this high altitude pulmonary edema, sir?
The high altitude pulmonary edema is a kind of pulmonary edema which is seen if you ascend a height away from the sea level suddenly. It is not a gradual this thing, it is a sudden ascent. So the precipitating factors are your exertion and pre-existing conditions. This pulmonary edema, high altitude pulmonary edema, can develop in any person, like be it a sportsman or be it an army man or anybody who does a sudden ascent to an altitude more than 3,000 meters, that is 8,500 feet. So the thing is, how do we prevent this? there are some regimens which advise acetazolamide to be taken before starting the journey. The ideal thing is you acclimatize yourself at the base where you are supposed to take rest. Acclimatize yourself to the environment over there. You are coming from a either less than sea level or just near the sea level. You acclimatize yourself and then start your ascent gradually so that the thing pulmonary edema doesn't occur. So how many days later does it occur? It can occur within 2 or 3 days, or it can occur even after 1 week. And it can occur in those people who are already residing in the high hilly areas, who come down to the base plains, spend some long time here, say months, then again go back. If their ascent is again sudden, again they have the tendency to develop the high altitude pulmonary edema. It is nothing but a severe form of acute mountain sickness. This is what I can. So you are not audible, sir.
Is there any prophylactic drug available for the high altitude pulmonary edema, sir?
That's what, sir. Acetazolamide tablet. That is a carbonic anhydrase inhibitor.
Thank you, sir.
So it should be started before the journey, not after you reach there. And you have to go. You have to take the advice of your physician or whoever is your this thing to see for the other. Because the other day I had a problem with one of my patients who took on her own, and she landed up in some other problem, seeking attention for a new problem there in out of station.
Thank you, sir. We'll move on to Dr. Vinit Kumar. Vinit Kumar, sir, how to stabilize patients with the pulmonary edema in emergency room? You were coming for the rounds routinely. Suddenly, one patient, known case of hypertension, first time coming to the emergency with the history of breathlessness, tachypnea, tachycardia. So, how to stabilize this patient in the emergency room? Yes, sir.
First of all, sir, we will give some IV diuretic and some afterload reducing agent, particularly nitrates, and an IV or BiPAP, whatever available there. And if there is a sign of fluid overload, we will start the continuous infusion of Lasix also, and look for any new onset call like some recent myocardial infarction, and then to timely revascularize that territory of myocardium which has responsible for sudden onset dyspnea. And so look for some immediate cause of this decompensation like myocardial infarction, some new onset arrhythmia, some patient with a new onset atrial fibrillation with very fast ventricular rate, they can land up in pulmonary edema. So we use of some antiarrhythmic drug like Codron or Lenoxin if BP is not supportive. If BP is supporting, you can use deltazam or beta blocker infusion to control their arrhythmia. And look for some, if patient is very unstable, BP is not recordable, we can use this inotrope, high dose inotrope, whatever like dobutamine or noradrenaline. And so we have some device like intra-aortic balloon pump that can reduce this afterload. We put a balloon in descending aorta below this origin of left subclavian artery. And with each cardiac cycle, it causes diastolic augmentation and increase the coronary perfusion and decrease the afterload. And that can help in unloading your heart. So besides drugs like antihypertensive, nitroglycerin, Lasix, BiPAP, and IV, control of new onset arrhythmia, control of heart rate with antiarrhythmic drug like Codron infusion or beta blocker. We have some devices like intra-aortic balloon pump, and some look for reversible cause of this ischemia like massive MI. Large portion of your myocardium is compromised. So you have to timely open that artery. Before that, large area of myocardium become permanently damaged and dead.
Yes, sir. The stabilization starts from the simple oxygen, non-invasive ventilation, either CPAP or BiPAP, diuretic, NTG,
Yes.
and the anti-arrhythmic drugs, either Cardorone or Diltiazem, to the intra-aortic balloon pump. There are a lot of, we have to see the patients and case to case, there is a
Yes,
very
sir.
key modalities. Thank you. So now we move on to the nephrologist, Dr. Sasidhar, sir. What is the role of pleural tapping? Any role of fluorosynthesis? When to do? Indications of fluorosynthesis in the case of yeah.
I think any unexplained pleural effusion or any suspected infections were like tuberculosis or something like that. I think those may be the indications, but that is what I think. So,
Yes.
because generally we don't try to tap whenever the patient is extremely breathless, because sometimes tapping of more than 1 liter can lead to re-expansion pulmonary edema. So any unexplained pleural effusion, if we see or if we think that it is an infective etiology, then we tap generally.
Go to Dr. Neel Thakkar. The role of non-invasive ventilation, especially comparison with a high-flow nasal catheter with NIV for patients with a respiratory failure and pulmonary edema. Kindly unmute Neel.
Am I audible? Hello?
Yes, audible Neel. Yeah.
So I'll just take part of the previous question also. Specifically in patients with pneumonia and sympneumonic effusion, if they have a synchronous, that two etiologies are coexistent, a lot of time we find that a patient has a secondary infection as well as pulmonary edema. In such cases, despite diuresing, if there is significant moderate effusion which is persistent and the patient is not that tachypneic but does have a significantly high oxygen requirement, in such cases we need to make sure that the pleural effusion which is collected is not only because of the cardiac etiology. If there is any other cause, that may help us, and if there is a secondary malignancy elsewhere, so in such cases also to define the etiology. Also, for specific your question, when we define for HFNC or NIV, so again, high flow nasal cannula is a relatively newer modality, but in the recent times, especially post the COVID pandemic, we have been using it day in and day out for respiratory failure patients. The prerequisite has to be we need to rule out any contraindications. So if a patient has a surgery of a face, nose, or the airway before, just recently done, then again HFNC may not be that helpful. With a recent upper airway surgery, there is a theoretical risk that the high pressure of the nasal cannula can also precipitate a venous thromboembolism. Besides this, patients with abdominal distension, aspiration, or a very high risk of pneumothorax. Again, it is relatively lesser compared to NIV, but HFNC also predisposes a risk of barotrauma. If where we use, and also the patient's CO2 level needs to be normal. The benefit of using HFNC is the nasal prongs are very small and pliable. The warming and humidification effect also helps with the secretions. It kind of helps with the congestion and even mobilizing the secretions. The washout of the nasopharyngeal dead space, as well as the CPAP effect, because of high flow, the nasopharyngeal pressure peaks at the end of expiration to give a PEEP effect, and it also reduces the inspiratory effort in such cases. Besides that, the NIV is definitely, we have discussed already that it is significantly useful, especially in pulmonary edema cases where the CO2 levels are high or there is a concomitant chronic obstructive pulmonary diseases. It will help in reducing the respiratory rate. Even we need to identify wherever we are using HFNC or NIV, identification of failure is important, because when, especially with HFNC, if we find that over a period of 6 hours the HFNC is not working, so there have been studies comparing early failure and late failure. So late failures have been associated with a higher mortality. So that is beyond 6 hours when they were able to identify that HFNC is not working, and earlier, less than 6 hours, the relatively mortality difference does exist. A parameter known as a ROX index, that is the peripheral oxygen saturation based on the fraction of the inspired oxygen divided by the respiratory rate. It can help. In a small series, they found that if the ROX index is more than 4.8 at 2, 6 and 12 hours post HFNC, there is a relatively lesser risk of this patient needing intubation later on. So again, these are some parameters for helping us in utilizing HFNC in such cases. NIV we have discussed in detail previously in the presentation as well as the earlier question. It is a very significant and important role, but only that the trials should be short and under observation. If we find that the patient is remaining persistently tachypneic on the non-invasive ventilation, even if the etiology is definitely pulmonary edema only, but there could be an underlying other cause, and we do not want to put an end stage intubation, wait right till the end. In such cases, if we know that the patient's blood gas is worsening, there is respiratory acidosis, we do need to go for early invasive ventilation in these cases. Thank you.
Thank you for this update on the NIV. So when to start HFNC, when to start NIV, when to give the invasive ventilations. This is all a case-to-case basis we have to follow. So thank you. We'll move on to some chat box questions. So Dr. Sumati from Tamil Nadu, Coimbatore, what is the treatment at primary health center, PHC level for pulmonary edema as an emergency, please? Primary health center level. So what drug we have to give as for pulmonary edema? Primary care. Yes, cardiologist or Vinit sir, you can answer. Vinit sir or Neel, you can answer, no issues.
So at the primary healthcare level, again, a diuretic, normally furosemide is routinely now available in normal or normal pressure or hypertensive patients. Now the same, I think, person has asked in the next question that if the pressure is low in such cases, then what do you do? So again, here in such cases, whenever we are sure that this patient has pulmonary edema, as Dr. Dayanand sir has showed us all the clinical signs, even discussed the basic radiology. So if a patient has a raised JVP, pedal edema, tachypneic, you find bilateral coarse crepitations which are present, the patient does have a previous cardiac comorbidity. These are all signs that you are dealing with only pulmonary edema and not a secondary infection. In absence of a raised JVP, with hypoxia, with bilateral crepitations, you still have a doubt that this could be a secondary pneumonia also. But in such cases where the clinical signs are very evident, we give 20 mg of furosemide at that time. If the pressures are very low, we try to make sure that this could be a secondary etiology also, that the patient could be presenting with sepsis to you, with early shock. If we are still wanting that clinical suspicion is high, but we do want to give a diuretic, we try to optimize the blood pressure first, either in that time, if based on what is available with you at that time, in a limited setup. A lot of times we also need to use noradrenaline, even peripheral NORAD. We do use with 1 ampule of 4 mg noradrenaline in 250 ml of either 5% dextrose or normal saline, which can be given as a peripheral infusion to improve the blood pressure. Otherwise, even in cases where that is not available, albumin can also be in emergent situations to improve the blood pressure. We might have to use, but we need to be sure we are dealing with a pulmonary edema in that case, because if at presentation there is significant hypotension, we need to make sure that this is not a secondary infection. As a treatment, there would be aggressively giving this patient IV fluids right at the start. So to differentiate that this is pulmonary edema or a secondary infection becomes very important. History of fever, history of cough with expectoration, new onset radiologic opacity such as which can point towards pneumonia, auscultation with bronchial breathing or increase if you find that the vocal resonance is increased on one particular side, these are things which can point towards an infective etiology. So I hope this helps with the prime presentation in a prime PHC level. That.
Thank you, Neel, for this wonderful answer for that question.
Sir, your voice.
Yeah. Dr. Damodaran Madhavan from Tamil Nadu has posted one question about the edema, cardiac and non-cardiac causes drug selection formula. Is there any drug selection formula for cardiac or non-cardiac? Dr. Vinit, are you there? Vinit Kumar? Vinit Kumar?
No, sir. I don't know any formula.
Okay.
Depending on just our goal is to reduce afterload aggressively, reduce afterload, preload, and then give after reduction of afterload, give diuretic so that we can take optimal effect of your diuretic. If in heart failure patient when afterload is very high, if you give large dose of diuretic, it will not go to your kidney. It will not have a full impact. Its full impact. So before giving diuretic, optimize your drug like NTG and decrease preload and afterload. And in high dose, this NTG has good effect on reducing afterload. And some of the case we can use IV enalapril or enalapril to decrease afterload and control blood pressure aggressively, and then give a good dose of IV diuretic. Suppose patient is taking 40 milligram of diuretics, and even after 40, you have high, sign of volume overload, and patient is decompensated. Then we should look for pathophysiology like diuretic resistance, and we can combine two diuretics, like combine furosemide with metolazone. So we can have, particularly in case of kidney disease and heart failure, when diuretic resistance is very high, when we can combine two diuretics like furosemide with metolazone. And before giving my message, before giving diuretic, you have to decrease afterload and preload.
Thank you, Dr. Vinit, for this wonderful crisp answers for this. And one more question from Dr. Krishnamurthy from Tamil Nadu is asking about that. Is there any role of morphine currently used in the management of pulmonary edema? Role of morphine?
In older days we use, but in case like we have seen increased incidence of intubation, although it has a effect in reducing preload afterload, but whenever I use, I have seen there is a more chance of going into intubation, elective intubation. And so I preferentially do not use, in SOS cases I use morphine, but I preferentially avoid morphine.
Thank you, Vinit. We'll move on to Dr. Dayanand, sir. Question related to the recurrent pleural effusion in a case of cardiac failure or renal failure causing recurrent effusion. Is there any role of pleurodesis? Pleurodesis in a case of transliterative recurrent pleural effusion. Pleurodesis.
Plain recurrent pleural effusion because of cardiac or nephro, we wouldn't go for, because it will be occurring again. So chances of failure will be there high. But in spite of that, if you feel that the effusion is because of some secondary pathology also coming into the picture, then it is worth trying. Like especially if you are having an undiagnosed pleural effusion and we have taken care of the edema, everything, all this thing, and still the pleural effusion is occurring, then we have to go further and do a biopsy, pleural biopsy, and put an ICD and then plan for a pleurodesis. But otherwise, pulmonary edema as such, there is no role of pleurodesis.
Thank you, sir. Now we move on to Dr. Vinit Kumar. So in the case of cardiogenic pulmonary edema, we have almost we have tried all the medications, starting from the diuretic, NTGs, and the supportive managements, so oxygen, everything. This is a chronic cardiac failure causing recurrent pulmonary edema, recurrent problem. So you are doing echocardiography, it's a very poor LV dysfunction. You give optimal therapy for the cardiac failure and all. So when will you consider heart transplantation, cardiac transplantation?
The voice is breaking, sir. Can you repeat yours?
Yeah. Role of heart transplantation. Role of heart transplantation in a case of resistant cardiac failure.
Before subjecting them for heart transplant, if myocardium is dead, very much dilated, severe, we have some of the devices. Suppose patient of severe LV dysfunction, and in ECG there is a broad QRS complex. So we have a device called combo device. We call it cardiac resynchronization therapy. So when there is a severe LV dysfunction, there is a dyssynchrony between RV and LV. So we have a certain ECG criteria, like you have broad QRS complex more than 130 millisecond, and after giving all sort of drug, we have some of the wonderful drugs like beta blocker. We call it beta blocker ARNI, SGLT2 inhibitor, dapagliflozin, empagliflozin, and this sacubitril valsartan combination. All these drugs has proven very helpful when in improving ejection fraction of patient. But even after optimizing all these drugs like beta blocker, SGLT2 inhibitor like dapagliflozin or empagliflozin, aldactone to maximum dose, and this ARNI, we call it sacubitril valsartan combination. We call it FAB4 or four pillar of heart failure therapy. So before subjecting them to heart transplant, we gave them full trial of this drug to optimal dose, whatever these patients tolerate, depending on their side effect and depending on their blood pressure and all. Because all these patients, when severe LV dysfunction, do not tolerate all these drugs, because all these drugs have some BP lowering effect. And but whenever we possible, we should optimize these four drugs in heart failure leading to recurrent pulmonary edema. We call it beta blocker. Second one is your SGLT2 inhibitor. Third one is your sacubitril valsartan combination, and fourth is aldactone. And even after optimizing the drug, we should look for some reversible. If myocardium is not permanently damaged, it's not we do viability study, and if myocardium is viable, we should revascularize that artery by opening that artery. We have some wonderful device. We call it cardiac resynchronization therapy. Although it is little bit costly, but it will synchronize all three chambers, like right atrium, right ventricle, and your left ventricle. And we have seen a significant improvement in their LV ejection fraction over 1 to 2 years. Because heart transplant is not available, and we have long queue for that, be it availability of organ or availability at different center. So as a cardiologist, I rely on these four drugs. We revascularize their territory if some myocardial. If some patient have severe valvular dysfunction, like severe aortic stenosis, aortic valve is severely stenosed, severe mitral regurgitation, we have some device. We can put them percutaneously. We don't have to open their heart, and we can percutaneously replace their aortic valve. We can percutaneously replace their mitral valve. If a patient have severe mitral leak, and we can give them option of mitra clip. If patient have severe aortic stenosis that in long term leading to decreased ejection fraction, we can percutaneously replace their aortic valve, and we can give them option of this cardiac resynchronization therapy. And even after doing all this, or some patient not fitting into all these criteria, like for candidate for CRTD or for replacement of aortic valve or mitral valve, we can give them option of heart transplant. But before heart transplant, we have some devices. We call it left ventricular assist devices. Although it's little bit costly, like 20 lakhs, 30 lakhs, 35 lakhs, and these devices we call LVAD, that can act as a bridge to transplant. Or some patient like severe myocarditis with COVID or some viral myocardia, we can give them the option of this left ventricular assist device till their heart function improves. And I've seen some of the patient waiting for a heart transplant, and with these drugs and left ventricular assist device, their LV function improves and they don't need heart transplant. But some of the case when myocardium is very dead, LV is very much dilated, we don't have any option but to refer them for heart transplant.
Thank you, Vinit. for this wonderful, elaborate answer for this heart transplant. Before the heart transplant, we have to optimize the medical treatment with a lot of drugs, and finally, we have a bridge treatment for the transplant like left ventricular assist device, LVAD and all. So thank you. So it's a similar question I'm going to pose to Dr. Sasidhar, the nephrologist. So when will you consider the role of kidney transplantation in a case of recurrent pleural effusion or recurrent pulmonary edema due to nephrogenic cause?
Generally, we take them for transplant whenever their cardiac function is good, because before transplant, all diabetics will undergo an angiogram. If their heart function is good, if their myocardium and other things are fine, then only we proceed for transplant. And very high risk patients, if they're very insistent on the transplant program, we ensure that the cardiac wise they don't have any issues. Otherwise, post transplant again, these things will recur. And we had one such patient with a high risk we have taken, and then suddenly he had arrested in the transplant OT, but luckily he had come out. So assessing the cardiac function before transplant program is very essential, and assessing their lung function. So for all our transplant patient, we ask for a cardiology clearance, we ask for a pulmonology clearance. That is a very much essential for all our patients. So like what Neel was saying, it is always a multidisciplinary approach, and we should all practice that, and that will help in betterment of our patients.
Multidisciplinary approach for any disease. If you take pulmonary edema is for a complex disease, which involves a lot of specialists, so it needs optimized medical treatment. Then we'll plan for the transplant if the patient requires the other organ is fit enough to undergo the procedure. Thank you. Now the question to Dr. Neel Thakkar regarding what is sympathetic crashing acute pulmonary edema and fluid overload subacute pulmonary edema. How is presentation and management different for these two entities?
So, sir, these two are relatively like we have phenotypes for asthma. These are some specific phenotypes for pulmonary edema. So, especially in patients who land up in the emergency room. So, if you have a sympathetic crashing acute pulmonary edema, that is SCAPE. So, that is like a flash pulmonary edema with accelerated hypertension. There is significantly higher blood pressure when the patient presents to you. The acute is very rapid. Patient is very critical, and there is excessive afterload causing the fluid to shift into the lungs. The patient can be either euvolemic, hypovolemic, or hypervolemic, but definitely is hypertensive. So the goal here is we have to give early respiratory support with CPAP or BiPAP, and nitroglycerin here becomes the most important drug as we have to reduce the afterload. Even though signs of systemic congestion may be absent in these scenarios, the other scenario is fluid overload, subacute pulmonary edema, where the patient has significant congestive heart failure or decompensated heart failure, which is normally gradual. Patient may or may not be critically ill because this has happened over a period of time. Patient is definitely hypervolemic. So the role of decongestion, even in cases the patient is so congested that needs aggressive diuresis or even dialysis in such cases, there could be ascites or peripheral edema, which is very common. So these are two specific phenotypes where the management is completely different, as well as the focus, even though if we may need to give NTG as well as diuretic, but the urgent and the immediate management in such cases would be nitroglycerin for SCAPE. There is the main etiology here is the sympathetic activation as well as vasoconstriction, and we need to take that fluid out of the lung as well as reduce the afterload. So these are two specific phenotypes which require specific urgent care in the ER or the ICU accordingly. Thank you.
For this specific two phenotypes of pulmonary edema, we have to identify and do the treatment appropriately. Thank you. So we had a wonderful multidisciplinary discussion on pulmonary edema. So almost we are coming to the end of this program. So thank you all the panelists. May I request all the panelists.
Sir, audience question. I think one or two audience questions are
left. Please. I'll go to that. Yeah, that was questions. Dr. Abhishek Chandra from Uttar Pradesh, use of Lasix infusion. So already we have discussed. Anyway, so once again, Dr. Neel or Vinit, you can address this question. Role of Lasix, IV Lasix infusion. Yeah.
Sir, here I think because we have a cardiologist as well as a nephrologist with us, I think we've described that 5 mg per hour up to a 20 mg per hour Lasix infusion definitely we do utilize. But my question here, since we have two other specialists of other branches with us also, is that when with a patient who has on diuretic a rising creatinine, then in such cases, do you use albumin with the Lasix infusion in your practice? And if yes, then in where and how? So this is again, as I wanted to have this discussion, especially because we have both a nephrologist and a cardiologist with us. So specifically in cases with diuretic, especially because this is a common case scenarios most of us face with patients with severe pulmonary edema, is that once you start using the diuretic, gradually the create starts to rise. So in such cases, how do you manage these patients with especially those needing Lasix infusion? So Dr. Shankar or Dr. Vinit, if you can please discuss this.
Yeah, from nephrology point of view, we generally observe that whenever you give diuretics, we find a pre-renal kind of situation. Urea goes disproportionately high to the creatinine. Creatinine also goes up. So again, it is a balance of the clinical judgment, and also there is no fixed rule as such. Sometimes when there is not much of edema, we come down on the dose of diuretics. Sometimes patients are on dual diuretics. Sometimes some people put them on triple diuretics. So again, it depends on the patient's edema, the patient's clinical features, and then optimization and titration. Because sometimes when we put them on valsartan sacubitril, again the creatinine goes up, potassium goes up. So basically, it is you have to see the patient in total and then decide about the diuretics, about the Lasix infusion and other things.
Completely agree with Sasidhar, sir. That's what we have to analyze on case-to-case basis, depending on the
on case-to-case basis. What will happen is sometimes we both are in a little confusion because sometimes some people start on BD dose, TID dose of valsartan sacubitril, and we see the potassium going up, and again patient coming. This patient shifting from cardiology to nephrology, nephrology to pulmonology. This is very absurd.
These are all three interdependent. Whenever it comes to ICU patients, all three always depend on each other.
Whenever any patient comes to that, I say that we just need to adjust certain we need not disagree with what the other department has done or something like that. It is always a combined approach, and always patients can try to find faults that that has happened, this has happened. We calmly tell them that this requires a minor alteration in the drugs. It depends on your salt intake.
And sir, what we practice here is in such patients, we do a joint counseling only. So that's always resolves most of the things and prevents any related confusion in such scenarios.
Yeah, nowadays with a lot of medical legal issues, I think primarily we all should work together as a team.
Yes, definitely.
One question in the chat box. What is the exact question? Action of IV rabidin. Ivabradin or IV?
Ivabradin.
Yeah, Ivabradin. Yeah, I will take this question, sir. If patient is in sinus tachycardia, we should first rule out the cause of the tachycardia. What are the stress factor that is increasing his or heart rate before changing the tachycardia? So we should look for the infection. We should look for the creatinine. We should look for the some painful stimulus or some dehydration. And if after ruling out other cause of tachycardia, if patient we don't get any cause of tachycardia, we should control it with beta blocker in spite of ivabradin, because beta blocker has also additional role of decreasing sudden cardiac death. But in some of the situation where we cannot use beta blocker, like patient in COPD, severe bronchospasm, and patient blood pressure is not supporting, In that case, whenever there is a contraindication or patient is not tolerating beta blocker or some contraindication like severe bronchospasm, in that case, we can use ivabradine for control of heart rate. But again, if heart rate is high due to atrial fibrillation, most common entity we see in our ICU setup, that is atrial fibrillation, commonly associated with your heart failure or pulmonary edema or your COPD patient, like all these arrhythmia, like we call multifocal atrial tachycardia and this atrial fibrillation with fast ventricular or continuum. In that case, ivabradine will not work. It work only on sinus node. And if there is a multiple foci of origin, like in case of atrial fibrillation, most commonly associated with your heart failure patient, in that case, it will not work. So in case of MI or in other case, when it is high heart rate due to high firing of your sinus node, in that case, ivabradine will work. And my preference is only after utilize the maximum dose of beta blocker. Maximum dose of beta blocker and still your heart rate is not control of, then you can use ivabradine. Or if patient have some contraindication for beta blocker to control like severe COPD, bronchial asthma, patient BP is not supporting some baseline change or AV block, in that case, ivabradine we can use. I hope I am clear.
Very, very clear, Dr. Vinit Kumar. Wonderful, crisp and clarity, answer for this. So we had a wonderful multidisciplinary discussion on pulmonary edema, what, where, how to tackle. So in and around, we have dealt with pulmonary perspective, cardiology perspective, nephro perspective, and intensivist perspective. So thank you all for this wonderful participation. May I request all the panelists give some take-home messages to our beloved audience. Thank you. Over to all the panelists, one by one. Dr. Dayanand, sir, first to start from you.
Yeah. Today we had an enlightening discussion on pulmonary edema, what, where, when, and how to treat. So remember, eyes will see only what the brain knows. So kindly see every patient as a learning this thing, and try to diagnose the pulmonary edema in the earliest. Have a close interaction with your other specialty colleagues. You will learn a lot. That's what.
Dr. Vinit Kumar, you will take a message.
Thank you, Jayaraman sir. Thank you, Chest Council of India, for inviting me as a panelist. So it's a wonderful. Thank you, Dr. Neel, thank you, Dr. Sasidhar sir. Wonderful discussion about how to identify radiologically from pulmonary point of aspect. I got to learn some of the very nice points by Dr. Neel and Dr. Dayanand sir. And my point is we should, like multidisciplinary. From cardiologist point of view, I will advise everyone to go for auscultate for some additional sound, some murmur, to look for the cardiomegaly in chest X-ray available readily. And this chest X-ray and ECG, we cannot have, ultrasound machine to do POCUS or echo at everywhere. But we can have a small stethoscope by which we can see some loud murmur, some loud systolic. Sometimes it's difficult to catch diastolic murmur, but some loud systolic murmur at aortic base or mitral area, we can catch up with your stethoscope. Yeah, something is abnormal. Patient is orthopneic, some additional heart sound, and ECG and X-ray. These are the basic things. We cannot have NT-proBNP. We have to wait for 2 hours, 3 hours, 6 hours to get your NT-proBNP. But with clinical history and ECG X-ray, it's available everywhere. We can have some clue with your use of your stethoscope by auscultating S3, S4 or some systolic or diastolic murmur. We can have, this looks like cardiac origin. And in that case, we have to monitor their blood pressure, auscultate their lung field, assess the volume status, look for some JVP.
Wonderful, Vinit, sir. Wonderful take-home messages from your side. Thank you very much. Over to Dr. Sasidhar, sir, nephrologist. Your take-home messages for the beloved audience.
Yeah, like what sir was mentioning and what we all discussed, I think multidisciplinary approach is very essential. And during COVID time, I strongly believe that we all survived because of the pulmonologists. And it is a very systemic organization, and I've seen CCI doing a wonderful job. And sir, you especially, what a strict discipline and what wonderful way of conducting. I'm really impressed. At least our nephrology society should learn a lot from your society of very particularly the way you organize, the way questions have been raised, the way you received us and all that. I'm really impressed and I'm very thankful to you, sir.
Last but not least, over to Dr. Neel Thakkar for your take-home messages to our audience.
Thank you. Thank you, sir, for excellently moderating this session, taking this topic through in a very smooth way and covering all topics. So for take-home messages and all respected panelists, Dr. Dayanand sir, Dr. Vinit Kumar, Dr. Sasidhar sir, all for excellent discussion. So two take-home messages. One, that we all, when we see patients with pulmonary edema or where we are suspecting pulmonary edema, we even as be it us as pulmonologists, as critical care specialists, be it a nephrologist, be it a cardiologist, be it a resident doctor, if you're seeing this, we should never have a binocular vision. We try that, ठीक है चलो इसका सिर्फ respiratory cause रहेगा, सिर्फ renal cause रहेगा, सिर्फ cardiac cause रहेगा. We look at it from a far perspective as to the other aspects involved in that patient. There is a saying in medicine, primum non nocere, that whenever we do anything, we do not harm the patient. But in today's time, especially when I was going through news articles for this presentation, all the ones which I presented out of the last year, many of them from India. So we also do no harm to the patient, but we also have to ensure that we are also not harmed in today's scenario. So whenever you are dealing with critical patients, make sure that, especially if you are giving fitness for any surgical procedure, if you yourself are doing any procedure, if there's any other cardiac procedure, we don't not do any investigation thinking, especially in private practice. A lot of times we go with the mindset of saving cost. That patient का echo नहीं कराते, लगे तो pro BNP तो investigation का cost आ जाएगा. So in all cases where you think that patient has a relatively even minor probability that this could go high risk later, make sure that you do an echo prior, where needed do a pro BNP, because cases where the patient will decompensate either in the OT or later at home or somewhere. In today's time, it is, as a private practitioner, very important that you document what you have checked earlier, as well as you ensure that from your side, the patient has been sufficiently screened from a perioperative cardiac event later or during the procedure. Because even if there is a risk and you have not documented, when I went through all these cases, in all the cases, the doctors, most of us have been doing everything right. But a lot of times they might not be documenting what they have done before or post the procedure. So these are just two important messages besides the clinical discussion, the use of sonography also, which I've highlighted. But definitely we need to safeguard and document our own practice with safeguarding our patients is one of the messages which I feel specifically with relevance to pulmonary edema. Thank you so much, Chest Council of India and Jayaraman sir, for excellently moderating and taking us through this topic. Thank you.
Thank you very much.
Sorry, voice.
Voice system.
Panelists, Dr. Sasidhar sir, Dr. Dayanand sir. Yeah. I thank you all the panelists for the wonderful discussion, wonderful take-home messages. I thank you, Dr. Neel Thakkar, Dr. Vinit Kumar, and Sasidhar sir, and Dayanand sir. Thank you very much all. And this discussion, the final conclusion, very clear that, so quick assessment, detailed clinical history and examination, bedside ECG and echocardiogram, ultrasound. So we clinch a diagnosis and stabilize the patient. So with that, we give appropriate adequate treatment for the specific therapies to improve the patient health status. And further, we can do all the other investigation modalities for the survival benefit, etc. So this is one of the medical emergencies and chronic lifelong conditions We need to have a meticulous attention to the patient care with the multidisciplinary, with the investigations and protocol we have to follow to ensure the, to prevent unnecessary mortality and morbidity. So a lot of take-home points from all the expert specialists, Dr. Vinit sir and Sasidhar sir, and our intensivist and pulmonologist, Neel, Thakkar and Dayanand. Thank you very much. I thank you, Chess Council of India, our founder, trustee, Dr. N.H. Krishna sir, for a wonderful opportunity, and co-founder, Dr. Narayan Pradeep sir, and our CCI webinar coordinator, Dr. Channamsetty, and our leaders, mainly the authors of this program, Dr. Atri Gangopathy, Dr. Sivani Swami, and Dr. Kirat. There are a lot of leaders behind. So we are all enjoyed. We are learning so many points every weekly Thursday. So thank you, CCI, once again. Long live CCI. Thank you very much. So with that, I conclude this talk. So good night. Long live CCI. Thank you very much.
Good night. Thank you.
Long
Thank you.